At the conference, I was given an overview about the new advances in the treatment algorithm for metastatic colorectal cancer. In my presentation, I particularly highlighted the significant advances we have made in the molecular characterization of colorectal cancer. We have started to analyze the DNA mutation analysis and integrated now next generation sequencing technology to better understand the genetic makeup of colorectal cancer. I think what happens in the future, and it already has started, that in addition to next generation sequencing, we are now doing transcriptome analysis to better understand the downstream effect of DNA mutations as well as activated pathways, which could be target for new drug development. There were significant advances over the last 12 months, which I included in my presentation. One of them was the development and the presentation of G12C inhibitors for metastatic colorectal cancer. The data suggested that the G12C inhibitors are not as effective compared to the inhibitors in non-small cell lung cancer. And the recent publication and presentation at ASCO as well as ESMO GI showed why, because you have a negative feedback loop in colorectal cancer, upregulating significant activation of the MAP kinase signaling pathway, which is not present in non-small cell lung cancer. This actually has a consequence that not only the single agent is not effective, but should lead to more successful combinational treatment strategies by combining the G12C inhibitor with EGF receptor inhibitors or SHP2 inhibitors. So this actually leads the way for better, more effective treatment regimens, and early studies show that a G12C inhibitor with cetuximab has response rate over 40%. So I think colorectal cancer, because of its tumor heterogeneity, is a different disease and needs different treatments, even when we are targeting the same mutation compared to other cancers. The other advances, we have all seen the use of immune checkpoint inhibitors in microsatellite stable metastatic colorectal cancer. And unfortunately, they have not been very effective. Data from ESMO GI showed that maybe FC engineered antibodies targeting CTLA-4 in combination with PD-1 inhibitors showed for the first time significant and promising response rates with overall 24%. And when tumors with metastatic disease to the liver were excluded, the response rate was over 40%. We have learned that metastatic disease in the liver is significant immune suppressive environment, does not allow efficacy of immune checkpoint inhibitors as we use it today to be very effective. So I think we are on the way to optimize our immune checkpoint inhibitors, and this is the first time we could really understand that modification of these antibodies may lead to higher response rate. I think one other major progress was the presentation at ESMO GI on tucatinib. It's a HER2 inhibitor in combination with trastuzumab in HER2 amplified and overexpressing metastatic colorectal cancer. The response rate was 38% in highly refractory patient population, which actually leads to a new paradigm for this patient population. So all these data suggest that we identify more and more important targets for colorectal cancer, and the development of targeted treatments and modification of our antibodies will further increase the efficacy of our treatment strategy and algorithm for patients with metastatic colorectal cancer. So the future is bright. I think more molecular technologies will further advance the identification of targets and pathways, and we will see more efficacy in the future.